Okay. Hello, good morning. Today we'll be dealing with migraine. It's one of my favorite subjects. It is one of the most underdiagnosed conditions in medicine. And the fault lies not with the patient, but with us, because we do not spend enough time to analyze the type of headache the patient has. So once you make a diagnosis, it's easy. And it is a purely clinical diagnosis. There is no test to say this is migraine. There are only diagnostic criteria, but you can make a diagnosis clinically. So this is something you have to remember. Now, what is the etymology of migraine? Etymology means the origin of words. How did the word originate? Hemicrania. Hemi means half, crania means the skull. So a pain which was limited to half of the skull, that was originally called hemicrania. Over a period it moved to Latin, and when it came to late French, 13th century French, the HE went away and we are left with micrania. Then in the middle English, 14th century English, it became MYGREYN. So the pronunciation is almost the same, migraine. The spelling change. Again, it reverted to the old French. Migraine, the spelling we now have is from the late French. The reason we are dealing with it in such detail, because this is an ancient disease. This is not a new disease. This was described in the Ebers Papyrus, which was all discovered from the Dead Sea. They are part of the Dead Sea Scrolls. 1500 BC. So almost 3,500 years ago it was described. And Hippocrates, the father of medicine, has described the aura. So such an old disease. Unfortunately, still we are not, most of us want to diagnose it. Not that we can't, but we won't. Because we don't ask the necessary questions. You spend 1 minute more with the patient, you will make a diagnosis. Otherwise, the patient will be running around doctors and blaming them, not unnecessarily. Their blames will be worthwhile. We have to take the blame. So that being said, what is the definition of migraine? It is a primary syndrome of recurrent episodes of headache with sensory, motor or neurological symptoms in varying admixtures. So it is primary. That is, there is no cause in most of the migraines. You don't find any cause. And a syndrome, that is a constant constellation. That is an occurrence of 3 or more signs or symptoms is known as a syndrome. So headache is one prominent feature. Along with that, you always get 2 or 3 or more features with migraine. That's why it's a syndrome, and it is recurrent. It's not going to, once it starts, it's not going to go away. It will come again and again, and then it is episodic. So it's not brief. Once it comes, it lasts for quite a few hours or days. Then again it will recur. So it is an episode. It's not paroxysmal. Paroxysmal means sudden onset and sudden disappearance. Here it's not paroxysmal. It's an episodic syndrome. So this is what you have to remember. It keeps on coming years together. It will come, it will go, again it will come. So the classic history will be a few days of headache, followed by some remission sort of, and then again after a few days or weeks or months, again they will get. So taking the history, you have to ask this particular point. From when are you having this type of headache? Initially they'll say only 2 days or 3 days, but ask them right from 1 year, 2 years, childhood, did you have them? Then you will get a proper response. So this is the only headache without a structural lesion which persists for years. So that is a diagnostic clue. This is not described in textbooks. So listen carefully. Any headache which is persisting for years with remissions and relapses is severe in nature. No neurological signs. It's absolutely, CNS examination is absolutely normal, except during the phase of migraine. Therefore, there is only one diagnosis, that is migraine. If you remember this point, that's more than enough. And it's the second most common cause of headache, the commonest being the tension type of headache, they say. And as far as disability is there, so some sort of disability may remain with migraine. A lot of women are more than men, 15% women and 6% men, and clinically underdiagnosed. So there is no difficulty in establishing diagnosis, though the slide, I don't know where they got this slide from. Difficult in establishing, not at all difficult if you remember the criteria and some clinical points which will come to later. Okay. Then how does migraine suddenly start in a patient? There are certain factors which are known as triggers. So I have given a list. You can study this list. But this list, though it is from Harrison, I have added my own observations also. So bright light, sound, the inability to tolerate bright light, photophobia, the inability to tolerate loud sound, phonophobia. These form the minor criteria for diagnosis of migraine. But there are others: hunger, stress, physical exertion during menstruation. All events related to menstruation are known as, do you know? Anybody will answer what they are known as? I don't know whether you are listening or have simply put your phones on and gone off. All events related to menstruation are known as catamenial. So catamenial headaches are migraine. So menstruation can induce migraine. Lack of sleep or an excess of sleep. Red meat. Red meat means without any fat. Chocolates, citrus fruits, stormy weather, barometric pressure changes here, and alcohol, especially wine, that also can induce headache. So this is all from Western. Red meat, alcohol, they are more common in Western cultures, but even in our culture, those people who are accustomed to take wine can develop this type of a headache. Now, these are things which, these four or five things which I have noticed. Several people, every OP, especially those students who were with me in my OPs, might have seen, we diagnosed 2 or 3 cases with every OP. So even third semesters from my unit, or wherever I was working, I'm proud to say we'll be able to diagnose migraine. Whatever else they learn or not, I don't know. But definitely they'll diagnose migraine, because in front of them we ask a careful history. Within a matter of minute, you come to the history. The only problem is spending that 1 minute extra, right? So dark green leafy vegetables, especially amaranthus, gongura, certain vegetables like carrots or even tomatoes have induced migraine. Sunlight, this is a factor I discovered from the patients. Now, it's not my discovery. Several patients tell me, when I go out in the sun, I get severe headache. So I gave it a name, heliophobia, because they gave phonophobia, photophobia. I have added my own poetry, heliophobia. Helios means sun. Whether the thermogenic effect of sun is responsible, or whether the light it produces is responsible, or is it a combination, we do not know, because textbooks have not described this feature. And people are taking a shower in Western cultures and head bath in our culture. Most of them say after I take a head bath or a shower, I get this headache. And when they travel, especially on road, several people have told me when they travel by auto, they develop this headache. Now, auto travel is common in our country, Asian countries, not in Western countries. So their roads may be smooth, so they may not notice it much. But here, several people have told me once they travel in auto, coming to the hospital, they develop a headache. Then food additives, especially the colors. You might have, anybody going to a restaurant ordering Chinese food will see red color predominantly. Whatever you order, they'll put a lot of red color. Original Chinese actually use the sauces, but here our Desi Chinese, they use colors. Those colors are actually banned, but like all banned things, they're freely available in India. They use them, they give the red color to chicken or whatever it is. So they look appetizing, no doubt, but they can trigger migraine and they are harmful also. Next. So coming to the pathogenesis. So then how does the pain occur actually? So pain fibers are there in the meningeal vessels. They are supplied by the trigeminal nerve. So the pain starts with the pain receptors being activated in the meningeal vessels. First order neurons reach the trigeminal nucleus. The trigeminal nucleus has an important role in the appreciation of migraine pain. So this activation of trigeminal neurons releases neuroactive peptides like CGRP, calcitonin gene related peptide, 5-hydroxytryptamine, also known as serotonin, and dopamine. These are released. Then from the nucleus, that is trigeminal nucleus. Remember, trigeminal nucleus is the only one which is present throughout the brainstem. Throughout the brainstem. All other cranial nuclei, except the first and two, are present in the brainstem, but in defined areas. Trigeminal nerve nucleus, there are several nuclei for the trigeminal nerve. That's why it is spread throughout the brainstem. So second order neurons from the nuclei pass on to the ventrobasal nucleus and posterior nucleus of the thalamus. From there, they actually cross the midline, go to the pentothalamic tract, and then end up in the thalamus and hypothalamus. From there, this is the appreciation of pain. Suppose they appreciate 100 kilograms of pain, but not all that is appreciated, because day in and day out we are subjected to several painful stimuli, but we do not appreciate that much unless it is more. The reason being, when there is a appreciation pathway, there is a pathway for diminishing the pain also, anti-nociceptive effect. That is from the periaqueductal gray matter and the hypothalamus. They have descending tracts which decrease the pain perception. So decreasing the pain perception is also a feature of the locus coeruleus nucleus in the pons and the rostroventromedial part of the medulla, that is the dorsal rapus. Right. So from the first order neurons to the trigeminal nucleus, then second order neurons to the thalamus and hypothalamus, and then additional pathways to reduce. So it's always a balance between these two. In migraine, what happens is, there is a dysfunction of these ion channels, and then they stimulate these pain receptors, and the subsequent spread to the thalamus and hypothalamus. So why that dysfunction occurs, we do not know. Maybe some are due to the triggers, maybe some start de novo. And as far as the pathogenesis is concerned, there is one more concept, that is the genetic concept. So some people, they have a genetic basis for migraine. They are seen in families. It may be familial. Or they can be transmitted to mother has migraine, daughter may have migraine, grandmother may have, or sisters may have migraine. This is a common feature we can ask for. So there are other syndromes also. There mitochondrial diseases and the universal syndrome. These are having a genetic basis. So ion channel disease is also there. With the calcium, voltage gated calcium channel E1 2, sorry. And then the voltage gated sodium channel, SCM, and then sodium potassium ATPase channel. These are all can be affected. They develop dysfunction. These excitatory cations which lead to hyperexcitation. So finally, all said and done, what remember, it is intracranial vasoconstriction and extracranial vasodilation. So this the description was given in older textbooks. So whenever you want descriptions of disease or symptom or a sign, better go for older edition of standard textbooks. So they describe the diseases in detail. Nowadays, descriptions are becoming less. Reliance is more placed upon investigations and their findings and interpretation. If you want anything to be described properly, you read the older editions of standard textbooks. Right. So now the pathogenesis is over. Now we come to the clinical features. Clinical features. Now you can divide the clinical features of migraine into 4 parts. One is the aura. Though aura is present in only 25% of patients, it is not present in everybody. But aura, previously migraine with aura was called classical migraine, but we have got a separate classification which will come to later. Second of the clinical picture, second part is prodrome. The third part is the actual headache itself. Fourth part is the postdrome. So each migraine headache may have 3 or 4. If there is an aura, it's 4, it's not 3. So first we'll come to the aura. Aura technically is a perceptual disturbance of neuronal function. That is the definition of an aura. The advantage to the patient is it is a warning symptom to the patient that he or she is going to get an attack. So aura occurs in neurology in only 2 conditions. The thing we have dealt with earlier. What did we deal with? Where there is an aura? Which condition? No answer. Don't know whether you're listening or not. Last class itself I told you. It is seen in complex focal seizures. And now in migraine, classic migraine, so to say. So only 2 conditions to get an aura. It is beneficial to the patient because it warns the patient that she or he is going to get an attack so that they can take some preventive measures or treatment. Now, what is an aura? Aura is a dysfunction of ionic channels. which causes a excitation, that is excitation of the neurons in the cortex, and then followed by hyperexcitation. Hyperexcitation leads to a depressive wave. So this wave moves across the frontal cortex, entire cortex. So slowly it progresses at a speed of 3 millimeters per second. So this is known as the spreading depression of Liao. So this moves, and in over a period of time, it involves the entire cortex and the brain. So all parts of the brain are involved in the aura. But basically in the aura, what you see are visual symptoms. Visual symptoms like flashing lights, zigzag lines, zigzag lines moving across the visual fields. And in older textbooks, the description was given of a C like, see, the letter C. Some of my patients have also described. When I asked them to draw what they see, they drew a C in the paper. So they see the letter C. Why only the letter C, I do not know. Some see what is known as a fortification spectrum. That is, some lines going up and then coming down and again going up. So if you see, and it goes out in front of the eyes, it moves like that, like a film, like a movie. So from a distance, it looks like the outer walls of a fort. If you've seen big forts, outer walls, they are long turrets, and then some gap again are long turrets. From the gaps, they'll be shooting arrows or whatever they used to shoot. And the top turrets were used for observation of the enemies. So the type of movement, zigzag lines, but in a pattern, like a fort, that is known as fortification spectrum. So described by Huggling Johnson, the same fellow you got the Jackson, Huggling Jackson, same fellow who described the Jacksonian march. Right. So these are all visual symptoms. In addition, they may have different symptoms also, like confusion, but usually it's the visual symptoms which are described, and they may end up in scotoma, that is transient loss of vision in overnight. So how long does it last? It may usually last up to 40 minutes. That's what is given in textbooks. Now this aura is present in only 20 to 25% of patients. This was described first by Hippocrates. Now after the aura, next is the prodrome, the phase of prodrome, where patient feels tired, lethargic, confused. There are cognitive disturbances. Now, how long this lasts depends upon the patient, highly individualized, how long the prodrome lasts. Then comes the phase of a headache. The headache phase is also again variable in intensity as well as duration, and it involves a number of symptoms as well, not only headache. Headache is part of the syndrome. Then the phase includes several other symptoms of which I have given a list. The nausea, photophobia, lightheadedness, scalp tenderness. Now, this scalp tenderness, which is a specific feature of migraine, that is known as cutaneous allodynia. Cutaneous is skin, allo means other, dyna means pain. So the pain is in the meninges, but the patient feels scalp tenderness, and classically, unfortunately, they feel pain in the paranasal sinuses also. So what happens? The patient goes to an ENT surgeon. He will test these paranasal sinuses. He finds they are tender. He makes a diagnosis of acute sinusitis and then prescribes some treatment. This will only give partial relief. Again, the patient will run to another doctor. And finally, they end up with the ophthalmologist also. Ophthalmologist prescribes, you might have heard, glasses for vision. For headache. There are no glasses for headache. No glass will reduce headache. Only it's acts probably as a placebo, because they are not suffering from refractive errors. And here a diagnostic confusion occurs because some of the patients may be of the age when they develop a refractive error also. So whether the headache is due to refractive error or due to migraine or both is something for you to decide. To diagnose migraine, we have got diagnostic criteria. Refractive errors will be made out by the refractometry. So maybe there may be both, but they are not related. So even if a patient has been to an ENT surgeon or an ophthalmologist and they have produced some evidence of refraction, don't dismiss the headache as refraction alone. You look for other signs and to diagnose migraine, right? So cutaneous allodynia is something you have to remember, because patients don't always come exactly half the face, exactly throbbing in the eye and all that. So they come mostly with scalp tenderness. So all of the scalp, they may complain of tenderness. You will tend to dismiss the concept of migraine and think of other causes. So vomiting and nausea and diarrhea, all three are related. Visual disturbances, what you have said, this can continue. The aura is not a limitation. That is, when a prodrome starts, it doesn't mean the aura has stopped. Or when a headache starts, it doesn't mean the prodrome has stopped. So it may be continuum as a spectrum. Or it's usually a continuum, not a compartmentalized disease. Paresthesias, vertigo, photopsia, alteration in consciousness, especially cognitive disturbances, diarrhea, fortification spectra, that's what I've described now. Syncope, in the presence of syncope, again, classifies the migraine into different aspects, and the differential diagnosis also is different. It's not easy diagnosing syncope when you are suspecting migraine. Seizure, so almost partial complex focal seizures, they may mimic migraine. Confusional state. So these are only some of the symptoms, but some of them are definitely associated with headache. So that's why it's known as a syndrome. Now, when you examine the patient signs, now, so post-drome is also there. There also patient becomes weak, feels weak, and then he is in a mild confusional state. He will remain for some time. So if you look at him, it looks like a post-epileptic state also. So the difference between epilepsy and migraine is sometimes not easy to make out. Now, if you examine the patient, CNS examination is usually normal. There may be some tenderness. Because of the other symptoms, there may be tachycardia, bradycardia, conjunctival injection, or because of the apprehension of the patient, they may develop hypertension or hypotension, and transient hemisensory or hemiplegic neurological deficits. Here, hemiparesis is a real problem with migraine. Some of the people with migraine develop hemiparesis. So that is one cause of recurrent hemiplegia. Migrainous hemiplegia. This is described and it is true also. So all signs of hemiparesis can get migraine. Now coming to the diagnosis. Now classification. How to classify migraine. Now the International Headache Society is there. Believe it or not, there is a society for headache. International Headache Society gives the classification. The latest is 2018. Now they have given numbers to different types of migraine and other headaches also, but I am confining myself to migraine. Now they divided it into migraine without aura. Then migraine with aura, there are some special types. Migraine with the typical aura and headache is the normal classical migraine. Typical aura without headache can also occur. The aura is typical, but it can occur without headache also. So if it is without headache, it is known as acephalic. That is, cephalus means head. Acephalic means, so the head is not involved, only the aura is there. Now coming to 1.2.2, that is migraine with brainstem aura. This was previously known as basilar migraine or basilar artery migraine, because most of the symptoms are related to the posterior circulatory area. That is vertigo, diplopia or blurring of vision, confusion, syncope, and seizures. So these are all signs of posterior circulatory stroke actually. So when they occur with headache, we call it basilar migraine. So migraine with brainstem aura. Now it is called, it's not called basilar migraine, but the term you should know. Then comes hemiplegic migraine. So it is familiar. As we have seen, 1, 2, 3 types are there. Some people develop familiar migraine. It comes in families, just as we have described it previously. Or it can be sporadic hemiplegic migraine. So even without families, migraine may lead to hemiplegia. That's known as sporadic hemiplegic migraine. 1.2.3.2. Now coming to 1.2.4 is known as retinal migraine. Retinal migraine indicates recurrent lack of vision, loss of vision for a brief period. So this may be the only symptom. So it is difficult to diagnose if it is the only symptom. Most of the times, retinal migraine has an aura. So it becomes easy if there is an aura. Without an aura, searching for a cause for recurrent loss of vision is going to be complicated. Now coming to 1.3 chronic migraine. So migraine on a chronic scale is known as chronic migraine. Then what is chronic? How chronic is chronic? Chronic means more than 15 days per month there should be migraine, and within that 15 days there should be at least 8 or more episodes. So one episode of migraine may last 1 day or 2 days or 3 days. So if you count all the episodes, the total should exceed 15 days per month. Then it's known as chronic migraine. Chronic migraine definitely needs prophylactic treatment. So all cases of acute migraine may not need treatment prophylactically, but chronic migraine definitely needs treatment. Now coming to the complications described of migraine, status migrainosus, that is just like status asthmaticus, you get a status migrainosus or continuous headache for days together. This is not usual. Usually it resolves within 4 days or 5 days. Persistent aura without infarction. The aura may continue, like a migraine attack, it may continue. Or it may lead to infarction and lead to hemiplegia or quadriplegia. And seizure, migraine aura triggered seizure is there. Now coming to some borderline cases, they have written given as probable migraine. That is without an aura or with an aura, it may or may not be migraine because the diagnostic criteria may not be satisfied. Still patient may be not responding to routine therapy. Then you call it probable migraine. Episodic syndromes which may be associated with migraine. The gastrointestinal disturbances are described in migraine, especially the abdominal migraine, that is, and the cyclical vomiting syndrome. So more than this, what you have to remember the GIT is when there is migraine, gastric absorption time increases. So that is one of the reasons we give the dopamine antagonists like dopamine, metoclopramide, and we add some prokinetic agents also we can add. So they increase they decrease the gastric absorption time so that oral drugs are absorbed faster. So in case of migraine, there is a decrease in absorption of drugs. So that is the reason we add domperidone or metoclopramide, and then they also act as antiemetics also. Now coming to benign paroxysmal vertigo, this is not easy to diagnose from posterior circulatory stroke or from basilar migraine. They all present as the same way. Benign paroxysmal, if it is positional, you can say it is vertigo. If it is not positional, to diagnose, you have to undertake other investigations. And torticollis. Torticollis means stiff neck. Moving to one side, the neck will be there. And it can be paroxysmal and last for some time. So these are all described along with migraine. Now we have seen the etiology, the pathogenesis, and then the clinical features of migraine. Now how to diagnose? So there should be repeated attacks of headache lasting 4 to 72 hours in a patient with normal physical examination. And no other reasonable cause for the headache should be there. If there is an obvious cause for headache, you have to consider first that part of the obvious cause. There may be a migraine also, then again you have to make another examination. But in general, if you have an obvious cause for headache, the physical examination will not be normal. There should be some finding. So a normal physical examination should be there, and there should be no other cause to explain this headache. And those headaches should last for 4 to 72 hours. And then we come to major criteria, minor criteria. There are 4 major criteria and 2 minor criteria. Among the 4 major, you have to satisfy at least 2. The first is, and the most unreliable in our experience, is the unilateral. I might have treated around 500 cases of migraine. The unilateral I've seen very few patients. Usually they give a vague history, or unilateral later becomes bilateral. Usually it starts somewhere posteriorly on the scalp and then spreads and it becomes bilateral. So strictly unilateral, that is actually the classical definition of migraine, but I personally have not found it pretty useful. Throbbing pain. So the description of throbbing pain, only the patient can give you. How many people can give you a correct throbbing pain description? That also have reservations about. Aggravated by movement. This is accepted all over the world. Aggravated by movement. Previously, 2016 said aggravation by movement. Now they realized not only the head, the body moves, then the migraine can be intensified. So aggravation by movement. you're coming by auto, when the auto travels on Indian road, you can expect a lot of bumps and jerks. So therefore, your body is put under strain. So that will aggravate migraine. And moderate to severe intensity. So intensity, patient will definitely tell you very intense headache, extremely intense. So intense. I have seen some of the people, they ask others to put their foot on the head and press it. It will be so intense. Or some people will tie a band tightly around the head in the hope of reducing the intensity. So it is so severe. Now, can you tell me which is the most severe headache? Also known as thunderclap headache. Is anybody listening at all? So it is subarachnoid hemorrhage. The most severe headache a patient can experience is subarachnoid hemorrhage. It is also known as the thunderclap headache. So this is also very severe, though not at that level, but it's very, very severe, unbearable. Actually, the headache is very unbearable to the patient, that it should alert you to the possibility of migraine. Now, among these four criteria, you have to satisfy at least two should be there. Then minor criteria, nausea or vomiting, phonophobia and photophobia. Photophobia, the exposure to bright light, and phonophobia, exposure to sun. If you take this particular, among all these criteria, what I have found most useful is phonophobia and photophobia. Ask the patient typically, when you get that headache and somebody is talking loudly or the TV sound is on, how do you feel? Most of them will say, I feel very irritated, and they will actually beat whoever is available and weaker than them, especially children. So several women beat their children because the children make noise. These people cannot tolerate that noise and they beat them. So the headache will escalate to such an extent that they become uncontrollably angry. And if you ask them, so what will you do? They'll say, all will reply only one sentence. I'll switch off the light and sleep silently. Close the door and sleep silently. Because they cannot tolerate light, they cannot tolerate sound either. So phonophobia and photophobia, phonophobia especially occurs very rarely in other conditions. So it's one of the most diagnostic. I don't know why they put it in the minor criteria. If I were the authority, I would have put it in the major criteria and discarded the unilateral aspect. But this is a classification diagnostic criteria given by International Headache Society, so for whatever it is worth. But remember, always guidelines will be there to guide you along a path, but there may be so many deviations and so many additions. You have to keep on looking for something new. If something new occurs, then you have to investigate it, see if it occurs in other patients also. Then you formulate your own ideas, right? So these are the diagnostic criteria. So once you have made a diagnosis, is it so simple? It's not so simple making a diagnosis. Now we come to the differential diagnosis, because migraine mimics so many things, and so many things mimic migraine. It's not always easy. So complex focal seizures, they also have an aura. They also have sensory disturbance. Only thing there is loss of consciousness is predominant in complex focal seizures. And some of the migraines also may become unconscious, but not to that extent of complex focal seizures. And in the complex focal seizures, they don't fall to the ground. They remain standing, but of an altered sensorium, just like in migraine. There's one problem. So syncope. Syncope is a feature of bacillar migraine. So a syncope can occur due to other causes also. So many causes, as we know. And raised intracranial tension. This can cause severe headache. It can cause diplopia, blurring of vision. It can cause hypotension also. All the signs which are described with migraine. Cervical spondylosis. Classically, the pain is exaggerated by movement, by doing work. So this is one problem. Now, acute sinusitis is a manifestation of cutaneous allodynia can mimic acute sinusitis. Posterior circulatory stroke mimics bacillar migraine. Refractive errors, they cause headache, though which are recurrent if not treated properly. They can be recurrent, they can be episodic also, refractive errors. And remember, the refraction error can increase with age, up to the age of 35 years. Refractive errors keep increasing. So today they may be using some power, say minus 2.5. After 1 year, that may not be enough. So when it's not enough, it will again cause headache. So diagnosing it, whether it's refractive whether or migraine alone. We have to use the diagnostic criteria. And CVA, migraine can result in cerebrovascular accident, hemiplegia. When the patient is brought, he may be having hemiplegia. So you may think it is only hemiplegia, you give totally different treatment. And then benign positional paroxysmal vertigo. Other headaches like tension type headache. Tension type headache occurs in the background of tension. So usually the phonophobia, photophobia are not prominent there. Then medicine overuse headache. So most of the times what happens when people start taking analgesics, they get better and they continue treatment even without prescription, they keep on continuing it. They may develop headache due to NSAID usage, classically. Cluster headache. Cluster headache is differentiated from migraine because it occurs in clusters. That is, per day several attacks occur, and these attacks can continue for several days together. Then there will be a lapse. Then again, after some time, they get another cluster. So the onset is different. The treatment is also different. Though we use sumatriptan here also, 100% oxygen is to be effective, which is not useful in migraine. So these are some of the differential diagnoses. Now coming to treatment of migraine. Now all these tables I have taken from Harrison, they are not present in Davidson. So once you download it, go through them at their leisure, at your leisure. Now there are a lot of drugs for treatment of acute migraine, a lot of drugs for prevention also. So whenever a disease has a lot of drugs for its treatment, it means only one thing, that disease is not going to be get cured. So you can be sure it's diabetes or hypertension or migraine. So if there are a lot of too many drugs, it means the disease is going to be never cured. The only thing you can control. The treatment of acute migraine, there are a lot of people take a lot of things, but these are the available options. The first and the safest are the simple analysis, like a combination of paracetamol, N-acetaminophen is paracetamol, aspirin and caffeine. Caffeine is not now available, but it's a very good sedative. So if you take these, a lot of people get good relief. Next come the non-steroidal anti-inflammatory drugs, that is naproxen, ibuprofen, sulfonamic acid, diclofenac, in varying dosages which we have given, they can be used. These are best taken in early migraine. Now I've derived the same table from Harrison itself. And then comes the class of 5-hydroxytryptamine receptor agonist, that is ergotamine. Ergotamine is an ergot derivative. The specialty of ergotamine is it is a potent vasoconstrictor, extracranial vasoconstrictor and intracranial vasodilator. So it relieves the headache very well. It's one of the best drugs for migraine. But the problem is it has got a lot of side effects. It can potentiate a hypertensive crisis. It can precipitate a hypertensive crisis. It can cause gangrene of the finger. So the vasoconstriction can be so severe that the distal part of the limbs suffer ischemic gangrene. And if there is a pregnant woman, she may abort also. So this is the power of ergot alkaloids. So therefore, the treatment of the schedule of ergotamine is a bit different from others. Actually, previous indications were different. Latest Harrison says that you give one tablet at onset, then one tablet every half an hour, at the maximum of 6 tablets per day, and not more than 10 tablets per week. So actually you have to take it only for 2 weeks per month, not every week 10 tablets you keep on taking. Because over a period of time it accumulates to form a very potentially life-threatening hypertensive crisis. Then we have got the group of 5-hydroxytryptamine receptor agonists known as triptans, naratriptan, rizatriptan, sumatriptan, pravatriptan, palmitriptan, zolmitriptan. So all these, but variable dosages are there. But the problem with the triptans is they do not actually totally cure a headache. Once you start them, there is some relief, but the headache can occur even during the same 3 days. You give a drug, today the headache disappears, again it will come tomorrow. And they are not useful in the aura phase of migraine withdrawal. You have to give them only after the aura has crossed. Then one more thing is they are contraindicated in basilar migraine. Next. Dopamine antagonists like metoclopramide or chlorperazine and chlorpromazine. They are dopamine antagonists, which we use in this particular aspect, we use them to reduce the vomiting, which is a part of the migraine spectrum. Then there are known others, which are opiates. Opiates are not the drug of choice, but you can use them when it's very recalcitrant, not responding to any treatment. Then you can use. They provide symptomatic relief, but they are not the mainstay of treatment. And one more thing is they can promote dependence. Patient become addicted to opiates, so that's a problem. Nowadays, that's the reason. Meperidine is actually technically not available, banned in India. Meperidine, the classical trade name was Petidine. It's not available, it's banned in India. Right. Now we got neuromodulation. So suppose the drugs fail, all types of drugs fail. We can go for neuromodulation. This is only a something we can do in higher institutes only. That is non-invasive vagus nerve stimulation. You give pulse therapy, or you can give single pulse transcranial magnetic stimulation. Even if that fails, you can give ECT, electroconvulsive therapy. So there are some new approaches where we have 5-HT and calcitonin gene-related peptide antagonists like that, but they are not available right now. And when you use metoclopramide, it is best used as anything to increase gastric absorption of other agents. Right now I told you that gastric absorption of drugs is decreased in migraine. So you give metoclopramide, it acts also as an antiemetic also. So these are some of the drugs given for an acute attack. So what to do when the acute attack is over? Actually, we are trying to prevent the migraine. Now, do all people having an acute attack require prevention of migraine? Usually, now the guidelines say not necessary. So, when is prevention advised? When the migraine is chronic and there are more than 4 attacks per month. If you have more than 4 attacks per month every month, you keep on having 4 or more attacks, then you have to give preventive treatment of migraine. Where is the table I wrote down? So these are the preventive drugs. That is, the first is beta blockers, propranolol, metoprolol. Beta blockers are vasodilators, so they reduce the pain. Antidepressants like amitriptyline, nortriptyline, dosulepin you can use, or anticonvulsants, topiramate, sodium valproate, and serotonergic drugs, that is pitocin. Then others like flunarizine, which is an antihistaminic, candesartan, which is an angiotensin receptor blocker, and phenelazine, that is a MAO inhibitor. Phenelazine is reserved only for very resistant cases. It's extremely dangerous drug. So only for very resistant cases, they give phenelazine. Again, the neuromodulation, giving pulse therapy you can give. Finally, you can give onabotulinum toxide also, toxin, botulinum toxin. These toxins are best used in cosmetic surgery to reduce the bag-like structures below the eyes. So to efface them, we use, or they efface the creases of the face. So to look younger, people use botulinum toxide, especially the movie stars and those public personalities. They're not altogether safe, and they're better avoided. So these are the drugs available, some of the drugs available for prevention of migraine. You see that the list is long. So wherever there is a long list, the prevention is not going to be easy, not going to be permanent. Similarly, treatment is not going to be easy, not going to be permanent also. So what you have to remember in this particular migraine is the diagnosis is essentially clinical, and the investigations are usually not necessary unless you suspect some other coexisting condition. Third, treatment is highly individualized. So because so many drugs are there, what to choose for which drug, which patient, so that is highly individualized. You have to look at the patient characteristics, vital data, comorbidities, then select the drug. For example, patient is having bronchial asthma, you can't give beta blocker for preventive measures for migraine. So like that, you have to see the entire total picture of the patient, then decide what drugs have to be given for an acute attack or for a preventive therapy. And one more thing, you have to tell the patient in definitive terms that this disease is not going to be cured. It can only be kept under control when they get an attack. So once they get an attack, it's not that with treatment, they will not get it again. They will get it. But with preventive treatment, the duration between attacks decreases. So every 15 days they get, or every month they get. If you start preventive treatment, they may get at some later intervals, 3 months, 6 months, like that. But it is not going to go. For several years, it will continue in acute phase. Then later they may have episodic attacks, which we cannot define when and where. But that's something they have to live with. So this don't give a guarantee. Don't write MRI brain to every patient with headache. And don't give a guarantee at all that once this headache comes down, it will go forever. And all patients have to get refraction also tested, because in our hospital we see a lot of people have both refractive error and migraine. Some people don't have refractive error but are prescribed glasses because they go to an ophthalmologist first. So as a physician or even a general practitioner, you should not miss this simple diagnosis. The only thing is spend 2 more minutes with the patient asking a few questions and you can make the diagnosis.